With us right now is Dr. John Hovanesian from Harvard Eye Associates.
How are you, sir?
Good to
Great
see
be
you.
back, Ken. Yeah. So how have you been? You've got ears and eyes today.
Ears and eyes. You know, we're all set. You know, now we just need a throat doctor. And
That's right. That's right. You'll be back to the old ears, eyes, nose, and throat.
Yeah, I think at one time there was just one guy doing all that.
That was, and then we eye people just couldn't get along.
No.
We split off and formed our own specialty, right?
You know, often when you come on, one of the things you talk about are the latest advances, and as you have mentioned many times before, this area, Orange County, is kind of the Silicon Valley for eye care, right?
Yes, it is. You bet.
Yeah, it's amazing. And what's so nice about it is often you folks in this area, the eye care professionals, are often the first in line to kind of look at these new devices, look at these new implants and things we're going to talk about today, these new cataract lenses and all kinds of things. You get a chance, sometimes you're on trials to see, and it's really great for the community here.
It is. We're very lucky to live and practice where we do and to have the world's nicest patients like we do, because they send all their friends and relatives for us to take care of them. And because we do more cataract surgery than anybody in Orange County, or so we're told, we have a nice opportunity for companies who are local to learn from us and for us to learn from them.
Yeah.
And of course, no one ever is subjected to anything experimental or or investigational unless they understand it and very specifically choose to do so. But for a lot of our patients, it's great to be part of new things. People want the newest and best science, and we're pretty picky as to what clinical trials we do so that we know we're offering our patients what they want.
How long does that usually take? And we're going to look at some of the lens implants, how they've evolved.
Yeah.
From the start, let's say, to the time that maybe they're created in a lab somewhere, or by, I don't even know how that comes about, to the time it gets into someone's
Sure.
eye.
Well, there's a whole series of testing that goes on before humans even receive a new lens design or a new product, and we usually are involved after that has passed. It's occasionally we'll be involved in the first in human eyes testing, and that's always well known to patients if they're going to do that. We've been through some really wonderful innovations that way. You know, the basics of cataract surgery is pretty straightforward. What we're doing, and you can see a picture on the screen here, is we're replacing the internal lens of the eye. So here you see a cutaway of the front of the eye, and on the left side is the sort of yellowed and opaque natural lens that the patient's born with, and then on the right is an implant taking its place. And one thing you can see is it's a little bit smaller. The normal lens of the eye is about the size of an aspirin tablet. This is even smaller than that. But the optical part that we see through covers the pupil. That's the important thing for vision. And so that new lens can be of a variety of different designs and can be used to set the person's vision for the rest of their life, because we never need to replace or maintain these lens implants once they go in.
Yeah, and that's an advantage. And this kind of reminds me of, I think I mentioned this to you a long time ago, the cataracts, kind of looking at headlights on cars when they get old, especially the older ones. Yeah. And they, they get kind of fogged in and they get kind of yellowish. Well, in a sense, that's what's happening to your eye. I mean, it's a whole different thing, of course, but.
Yeah, but it's the same idea. There's a very gradual reduction in the clarity.
Right.
And for many people, they don't notice it. I see patients all the time who've got advanced cataract, and they say, it doesn't bother me too much. We look at their eye and we say, my gosh, it's amazing that you're able to pass a DMV test. Their vision is poor. For many folks, it's more obvious, and we never like to push anyone toward any kind of surgery that they don't feel they need. But in most cases, it's evident to the patient. We've seen some amazing evolution of the different lens implants over time, and and that's really an exciting development. So you'll see on the screen now a picture of a variety of different lens designs, and so these are the colors are kind of exagerated here. There are some that have a little yellow tint. The yellow tint or chromophore that you see on the picture in the right is even a little overdone too. But some of them have a little yellow tint to reduce glare. There's some debate over whether that really makes a difference for better vision. Patients don't seem to notice or care one way or the other in our experience. We more focus on the lens design. And some of these are designed to just be your basic lens implant. Some are designed to correct vision. And for example, the third from the left here, which has this sort of mustache at the top and the bottom, is called crystal lens. You've heard us talk about it. It's designed to mimic the natural focusing of a younger eye. Whereas others, the one to the left of that and then to the right of that, are multifocal lenses. And they have different focal points all within one lens. And for the patient, it's not like having a bifocal or a progressive lens in your glasses. There you have to tilt your head or look through a different part of your lens. With a multifocal implant, all of the light is focused both far and up close when you're looking at any object because it covers the whole field of view. The size of the pupil as it expands and contracts can make a difference in how it focuses, and usually these lenses are designed so that when you're doing reading, you're going to have a little better up close vision, and distance vision, we tend to look for more distance. But the lenses have evolved over time quite a bit. And we've got a picture, if we can bring it up, that shows how light is split between the different type of lenses. And this gets very confusing, and for the non-engineers who are viewers here, it may not be as obvious, but a normal lens ideally would focus light like at the top of the screen, the top two pictures, a single point of focus. And indeed, optically, that is sort of the ideal, right? You'd have the sharpest focus. But what you lose if you have that is the ability to see both far and near.
Right, exactly.
Things up close, we have to focus differently from things far away. So accommodating lenses, that's the second one, is designed to mimic that range of focus, like the autofocus in a camera, moving single point of focus. And they're a great technology because they don't degrade the clarity of the point of focus, but the range is limited. They can't get from way far to way up close. And that's where we have to do things like make one eye a little more nearsighted than the other to sort of fake it, to adjust and extend that range.
So you do that with the one eye may get a slightly different lens than the other. In other words, the abilities of that lens, I should say.
That's right. The focus might be a little more up close and which works for the majority of people. I guess the second way to do it is with either a diffractive or a multifocal lens, and those are the type where there's some degree of splitting light. So at any focal point, not all the light is brought to a single point of focus. The point is that there are trade-offs with any type of lens we use. And for some people, let's say you do a great deal of driving after dark, a multifocal lens might not be a perfect choice for you because you might have more trouble with headlights causing halos or glare. Cataracts themselves cause halos and glare. We're getting rid of that when we remove the cataract, but we're putting in an implant that may impart some small amount of imperfections. But the advantage of a multifocal lens is that it's got better reading vision without glasses than, say, an accommodating lens. So with each patient of ours, we try to look at what their needs are, and we use all the available technologies because we don't believe that there's a one size fits all. We try to match the technology to the patient. One exciting development, just because the plot is always thickening with science, is a new type of lens called an extended depth of focus, and there's a picture of that single lens.
And you can see the Fresnel type of lens in there.
And this lens has sort of a dominance in the center for distance vision, but it also, for the engineers in the audience, they control chromatic aberration so that they can not have a far and a near focus, but just take that single point of focus and extend it so that at nearer ranges, patients can see a little bit better. And with this lens, we've had very good results because with this is called the Symphony lens, S-Y-M-F-O-N-Y, Symphony. And this lens is successful because it really reduces the glare and halos I mentioned while giving patients a functional range of vision.
So let me ask two questions on this. The first question is, if there is a cataract in one eye and not both, are you going to you're obviously just going to replace that one eye, but still that person who maybe uses reading glasses may also get that additional benefit?
Yeah, it's a great question, and the answer is it depends. So often
just like you were saying, what's
That's
going to work
for them. So we always have to take into consideration how much cataract is in the other eye, what's the vision in that other eye, what does the patient normally wear, glasses or contacts or whatever. and of course what their needs are, as I mentioned before. So usually, yes, we'll only do the surgery in that one eye. But normally, we are planning for today, but also thinking about tomorrow.
Right.
Eventually, you know, most cataracts for most patients happen in both eyes around the same time.
Oh, they do? Okay.
Which is why many patients don't notice their cataracts.
Okay.
Because it's both eyes, it's everything they're seeing. So we plan accordingly, and almost always are able to come up with a solution that's really, really sort of seamless for the patient. What we want is you to have better vision and not to have to think about it. Just to see.
That's nice.
Right. That's technology is its best when it's invisible.
It is.
We don't
That's
have
true.
to think about it.
Now, again, with these lenses, you mentioned about the maintenance of them and all that, but what about 10 years from now? Do they need to be replaced if somebody's natural sight changes, their focal length changes?
So this is a great question, and fortunately, it's very rare that vision would change after cataract surgery.
Okay.
Throughout our life, we're used to the idea that our vision is going to change every few years, and that's because from up to about age mid-40s, we sort of are okay, and then we lose our reading vision, and then after that, we're developing cataract, and that changes our vision. But those forces are behind us by the time we get to cataract surgery. Mm-hmm. So when we replace that lens of the eye, that's about the only remaining element that's changing in the eye. So replacing it with one of these technologies, we don't expect ever to have to replace it again. And so, this makes it, when you have cataract surgery, it's absolutely an appropriate time to think about it as, here's the vision that I'm setting that I'm going to look through for the rest of my life.
Okay. Now, one other question, if I may.
Sure.
How long does usually the procedure take? Are people, obviously the person's eyes are open, but do you give them some sort of a calming sedative or something? I've often thought about this where, you're getting something done in your eyes, it's going to be fantastic and all that, but looking up, seeing all this going on can be quite frightening for people.
You bet. Well, our eyes are, for most of us, our most precious sense, right?
Right.
And the idea that we're going to go through a procedure where somebody's doing something to our eyes is terrifying for many, many people. We get that. So everybody gets an IV with a lot of sedation. If you've ever been through a colonoscopy, you know that with the right mix of medicines, for most people, it's very, very easy and quick and over with. And it's a similar thing. We give sedation, and we also numb around the eye with eye drops so that you're not seeing and you're not feeling anything during the procedure. The procedure takes 5 to 10 minutes to perform.
Wow, that's amazing.
And most people don't have pain afterwards, a little scratchiness for maybe a day or so. And actually the next day they can get back to reading and driving and using a computer and doing most activities. Amazing. We just ask them to avoid vigorous sports type stuff for about a week and not to swim for 2 weeks after surgery.
All right.
So there's not much downtime.
Very good.
Yeah.
Always
pleasure.
Good to see you, sir.
Always a pleasure.
Great innovations, and it's a great area to be in for eye care. And as you said before, all the stuff that goes into this area and that all the people can take advantage of, and the eye care professionals and all, it's great.
The technologies are amazing and just getting better.
Yeah, it is. Good to see you.
Good seeing you.
And we'll be right back.